I'm incredibly pleased today to be able to introduce to you Dr. Ruth Paterson, who's Head of Learning and Teaching in the School of Health and Social Care at Edinburgh Napier University, and she will be taking you on this journey into pharmacology today. Just before I hand over to Ruth, just a little bit about her. Ruth registered with the NMC as an adult nurse in 1992, a lecturer in 2007, and a non-medical prescriber in 2010. She completed a master's in philosophy and law and ethics in medicine, at the University of Glasgow in 2000. So she's very busy. She's recently completed her PhD, which was mixed methods study that developed and tested a theoretical model to predict medicine's adherence in people with intellectual disabilities and diabetes. And in 2018, she was invited to be subject matter expert during the development of the Nursing and Midwifery Council standards on pre-registration nursing and prescribing. In 2019, she was appointed as Accountable Officer for Pharmacology and Prescribing Preparedness at the Future Nurse Board hosted by NHS Education for Scotland. So I think you'll agree with me that you're in very safe hands today. Ruth is also co-author of Trouns's Pharmacology Practical Prescribing, publishing by Elsevier in 2022. So without further ado, I will hand over to Ruth for the session. Thank you, Ruth.
Thank you very much, and welcome to the session, everybody, and hopefully I'll be able to give you a short whistle-stop tour of some of the key principles of pharmacology. Now, of course, in 30 minutes I'm not able to cover in-depth knowledge, but hopefully it will give you a foundation from which you can work from during your studies. Okay, so as the introduction stated, I'm Ruth Patterson. I'm an Associate Professor at Edinburgh Napier University with a specialist interest in pharmacology, prescribing and medicines management. So hopefully I'll be able to give you some insight. What I'm going to do in this session is just introduce some core concepts relating to pharmacology for nurse and allied health professional practice. I want to provide a key outline of the key principles of pharmacokinetics and dynamics, and explore pharmacology in the context of a common clinical presentation, as that's somebody who's presented with an acute exacerbation of their chronic obstructive pulmonary disease. Now, I do have a Scottish accent. It may well be that I speak too quickly, so I'm really sorry if I do. There's a lot to cram in, but hopefully you'll be able to listen back to the presentation and be able to sort of follow some of the concepts I'm introducing. Okay. So the title of this is called Why Pharmacology Matters. Well, pharmacology matters because as nurses, we're responsible for quite a lot of time, particularly in hospitals, for administering medicines. And we know that quite a lot of errors happen as a result of administration. But we also know that people with increased knowledge and skills in relation to understanding pharmacology can influence those change and reduce the amount of administration errors that happen. Also, if we understand pharmacology, we know when it's important to start or stop or continue medicines for particular patients, because we know that adverse drug events can happen and are preventable, and something which as nurses we should know. In the UK, we have a very high number of nurses that are now progressing to a prescribing qualification. And so therefore, understanding pharmacology in your undergraduate programme is really, really important. So those are just some of the things. And pharmacology affects, is a knowledge gap that's needed for all nurses, whether they care for the very young or the very old or somewhere in between. So I just wanted to take you through just some of the routes of administration that we will be encountering as nurses when we're giving out medicines. So we've got local and systemic routes of administration. On this slide here, we've got local routes, which include ointments, creams, pessaries, some drops, inhalation drugs, which have a local route of administration, nebulizers and inhalers. And then we've got the systemic routes, the drugs that are delivered throughout the body, and larger doses are needed to get that same effect that you might well have. When you're using local routes of administration, you may well get fewer side effects with those patients because it's having a direct action on the site. But with your systemic routes, because it has to pass through the body, be absorbed, distributed, metabolized and excreted, often there are some side effects that patients will have. And when we talk about the systemic routes, we're talking about the sublingual or the buccal administration or parenteral routes like intravenous, and of course the oral route, which is the most common and the one which we're going to focus on mainly today. So what are we trying to do here when we're giving drugs? What we're trying to do is create a steady state within the body of drug levels, which means that we have to have the same amount of drug, we have to have the same amount of drug going in as going out so that it maintains the equivalent drug level to ensure that there's maximum therapeutic effect. And hence the reason why it's really, really important if a patient's on a long-term therapy that the treatment is continued with only minimal amounts of missing doses or reducing doses. And that's really important for our patients that have got chronic diseases. So going on to the sort of key terms in relation to pharmacology, pharmacokinetics is about what the body does to the drug, so how the drug moves through the body. Kinetic means movement, and so it's what the body does to the drug as it passes through the body. And then we've got pharmacodynamics, which is what the drug does to the body, and those are the principles of drug action, how that drug works to exert its effect on the body. The drug is the active chemical of the medicine. The medicine is how that drug is prepared, i.e. in capsule, tablet or liquid form. And the ligand is the molecule that binds to another or like a neurotransmitter that binds to a receptor. And we're going to talk a little bit about drugs that work on receptors when we look at our case study. But first of all, let's go into some more detail into pharmacokinetics. So, pharmacokinetics deals with the movement of drugs in, through and out of the body. During absorption, the drug is made available to the body for distribution. It's how that drug gets into the bloodstream. Once in the blood, it's distributed through the blood vessels to the site of action. And in metabolism, which mainly occurs in the liver, it involves the breakdown of the drug for excretion. And excretion processes are whereby the drug metabolites are excreted, generally in the urine and feces, that normally happens. So let's take each of those concepts just in parts. So what happens after the drug is swallowed? It goes into the gut, where it's absorbed through the small intestine mainly. It goes into the hepatic portal vein, down into the liver, and out into the systemic circulation. Okay. During absorption, the aim is to give the drug which is absorbed for the blood to get it ready for distribution around the body. Of course, when you give something intravenously, there's no absorption required from the gut, and the drug is given directly into the blood. Drugs move from the administration site and into the bloodstream, but they need to cross the GI tract wall and into the bloodstream. And drugs need to be fat-loving or lipophilic to cross those membranes of the gut easily. This is a drawing that one of my colleagues did that just talks a little bit about how the drugs are moved through the stomach and out into the liver and then into the systemic circulation. So your oral route is the most common route. The GI tract and the small intestine has a massive surface area to permit absorption. It's really convenient for a patient to take an oral drug and they can usually self-administer. However, the drug action can be quite slow if you give it intravenously, if you give it orally, sorry. If you give it intravenously, it will very much happen very much quicker. It doesn't have to go through that whole systemic circulation, it goes directly into the vein. Once it's been absorbed, it gets ready for distribution. and blood flow to the body tissues vary, and some of the drugs are distributed into the bloodstream, and there's some barriers to drug entry. That's the blood-brain barrier, which is a protective mechanism that prevents drugs from crossing the blood-brain barrier. But during distribution, blood flow could vary due to cold or shock, and sometimes you would give your drug intravenously if that was the case. And drugs travel within the blood in two ways. One is the free drug, where the drug is available to exert its response, and one is the bound drug. So how is a drug transported around the bloodstream? Well, the drugs attach themselves to plasma proteins which are found in the bloodstream, and they bind to those plasma proteins and are transported around the system then. When they're bound to plasma proteins, those drugs are not available to exert its response. It's only the free drug which is available to exert its response. Now, albumin levels vary according to age, level of nutrition. People with cancer have low albumin levels. So often those people may not require such a higher dose of drug because there's much more free drug because there's less plasma protein for the drugs to bind to. So it's something to think about when you're drug dosing with people that are very malnourished, people with cancer, or people that have got low albumin levels, like people with liver disease, that you may well have to adjust or reduce a dose of drug in order in order not to get toxic side effects. So just to repeat, just the free drug is the drug which is available to exert its effect on the body cell. The remainder of the drugs that are bound to plasma proteins will release by maintaining equilibrium. Going on to metabolism, some drugs are metabolized into their active form, and the drug metabolism generally happens in the liver. The drug is passed through the intestine, gets ready for distribution, and then goes into the liver. And some drugs, like codeine, are metabolized into its active form through the liver, so they're not active until they've actually been metabolized. Some drugs are completely metabolized and inactivated by the liver, and giving drugs by some routes, intravenous, sublingual, or PR, will avoid first-pass metabolism, allowing for the full dose to exert its effect. So you may well have encountered some patients in practice who are given glycerol trinitrate. Now, those drugs in the emergency situation are given either in the buccal cavity or in the sublingual cavity, sublingually. And that's because those drugs are 90% metabolized by the liver. So therefore, if you were to give it orally, the patient wouldn't get any of the medication. So as a result, that is why it's given sublingually and in the buccal cavity to avoid the inactivation of that particular drug when given orally. So what we're saying here is that in first-pass metabolism will influence how much of a drug reaches the general circulation for distribution to the body tissues. And it determines the bioavailability. That's how much of the drug is available to exert its effect. And that is expressed as a fraction of 1. So if a drug is not metabolized by the liver at all, then that has got a bioavailability of 1. But if something is metabolized, 90% of the drug is metabolized by the liver, and therefore only 10% of the drug is available, that drug has a bioavailability of 0.1. So this first-pass metabolism can occur in the liver and in the GI tract, but mainly in the liver. Going on to excretion. Excretion is usually by the kidneys into the urine. It can sometimes be via expired gases, bile, sweat, and breast milk can also affect the excretion of a drug. And we've got to be really careful for people with liver failure, because mainly drug excretion is through the kidneys. And we've got to be really careful with people with renal failure, because they've got reduced renal function, and as a result, they've got reduced amount of drug elimination and therefore increased risk to toxicity. As we know, renal function deteriorates with age, and drugs in the elderly population are generally recommended to be prescribed at 50% of the recommended dose in people less than 70 years of age. When we talk about half-life, that is a calculation that has been done during drug trials to determine how long it takes for a drug to be eliminated. And half-life is defined as the time taken for the plasma concentration of a drug to decrease by half. So that means that we can make an estimate as to how long it will take for a drug to be completely eliminated from the body after the last dose has been given. And for different drugs, it can vary from minutes to days. And in practical terms, it's really, really helpful because it helps us to determine dose frequency. For example, if a drug has a short half-life, it will be rapidly cleared from the body and will need to be administered in more frequent doses. So something like a drug, acyclovir, an antiviral drug, you have to give that 5 times a day because it's very rapidly cleared from the system. We know it's got a very short half-life. A drug with a longer half-life acts for longer and less frequent dosing is required. So a once daily dose of a particular drug, something like amiodarone, it only needs to be given once a day because the half-life is so long. Now, conversely, when you want to stop those medications, it will take about 5 half-lives for a drug to be eliminated from the body. So when patients come with toxic side effects, for example, and you're going to stop that medication, unless you've got something to reverse the action of that particular drug, it may well take a few days for that drug to be cleared from the system. But we can usually predict how long that takes by knowing what the half-life is. Half-life will be affected by renal function, as we know, and also how long the drug is taken to clear. So it's not an absolutely accurate estimate of half-life, but it's a good estimation of predicting how long a drug will take to be eliminated from the body. Now, what about pharmacodynamics? Well, drugs can act in a variety of ways, but fundamentally they interfere with existing cell activity. And the basic activity of cells are the natural mechanisms used to control cell activity. The body uses chemicals to signal change in cell activity, and these act with cell receptors. And this is an important mechanism for many drugs. However, some drugs will also act on enzymes, ion channels, or membrane transport systems. What we're going to look at is what the drug does to the body and look at one of the main targets for drug action, namely receptor agonists and antagonists. And one of the key parts of the nervous system, which is really, really important to have a good understanding of, is the autonomic nervous system. So to just give you a brief overview of that, I'm just going to take you through some of the functions of the autonomic nervous system. So here's a diagram of the autonomic nervous system. Its function is to control involuntary body movements of most body systems. It's made up of a series of nerves, and there's 2 divisions. There's the sympathetic division, which is fight or flight, and the parasympathetic division, which is rest and repair. And those 2 systems act in a complementary manner to maintain homeostasis. But there's common differences in features, which I just wanted to walk you through. So this is the sympathetic nervous system. It's made up of a variety of what we call adrenergic receptors. And these are alpha and beta receptors that, when stimulated, release noradrenaline and adrenaline, that are manufactured from dopamine and stimulate a response in receptors throughout the body. So what you can see there is when this system is stimulated, you will get vasodilatation of your coronary arteries. You'll get trachea, bronchodilation of your trachea and bronchi, and we need to remember that because we're going to talk about a person with a reversible bronchospasm later on in the session. You'll get peristalsis will be reduced when these receptors are stimulated, and you'll get dilated pupils, in addition to all the other functions that you can see there of your sympathetic nervous system. In your parasympathetic nervous system, you've got nerve fibres that release a chemical transmitter called acetylcholine, and these exert a rest and repair response in the body, which means that your bronchioles, it causes bronchial constriction, it can cause vasoconstriction, it can cause increase in gut motility when your parasympathetic nervous system is stimulated, and your pupils can constrict as well. So what you see there is those two systems working together to maintain homeostasis. And what some drugs can do is work together to manipulate the parasympathetic and the sympathetic nervous system to exert a response. So in summary, these are the sort of core functions of the autonomic nervous system and the sympathetic and the parasympathetic divisions of those. In your heart, if your sympathetic nervous system is stimulated, you'll get an increased rate and an increased force of contractions. Think about this in terms of anxiety-provoking experiences that you might well have doing an exam and getting a fright. Somebody scares you, or that's your sympathetic nervous system being stimulated as a fight and flight response to a particular situation. And then in your parasympathetic nervous system, that works in the opposite way, or in some ways it works in the opposite way. It causes a reduction in heart rate, reduces the force of contraction in the heart, and can cause bronchoconstriction. Think about how you feel after your Christmas dinner. When you've had your Christmas dinner, you're much more relaxed, and your body is metabolizing and digesting all of those foods, and you're feeling very relaxed. Okay. So how do drugs work? So in relation to how drugs work, drugs really mimic what's going on with the natural neurotransmitter in the body. So drugs work when they work on receptors. They work to either stimulate or block a response. And this is very similar to a lock and key mechanism. If the key, the neurotransmitter or the drug, fits into a lock, which is the receptor, a specific response will be activated, and that will be a specific response in the body, or in the case of a lock and key, the door will open. And receptors are like locks in that they need a specific chemical to be activated. And when a drug binds to a receptor and stimulates the response, it's known as an agonist. It's something which stimulates and releases a response and stimulates those receptors that it has been designed to do. And those that, when it blocks a response, it prevents the action of that particular stimulus on that receptor. Now, you can get drugs that are partial agonists, and often in substance misuse, you'll give a patient a drug that's both got an agonist and an antagonistic effect to reduce the side effects of a particular drug. But let's just keep it simple just now, and we'll look at two drugs which work on as an agonist and one that works on an antagonist, but exerts the same response. So this is our case study. Mr. Zaida is a 73-year-old male. He's got chronic obstructive pulmonary disease, and he's presented to the emergency department with acute bronchospasm. He's been taking his medicines regularly. He's been exposed to an allergen, which has really triggered this response. So what they did when they brought him into hospital is they gave him some nebulized salbutamol and hypertropium. It's a classic drug given together, but why do we give them together? And we're going to learn why these drugs are given to reduce bronchospasm in the next couple of slides. What we've got here is Mr. Zaida, and he's been given his salbutamol. And from a pharmacokinetic point of view, that drug is taken by inhalation. So it has a direct action on the lungs. Well, that's our intention anyway. However, when you give it via inhalation, it's very close to your esophagus, so a large proportion of that drug is swallowed, about 75 to 90% of that drug. And then it's acted on by the liver, metabolized, distributed to all the tissues by blood, and some of the drug may pass into the bile, and then it's excreted. And the half-life of that particular drug is about 2.7 to 5.5 hours. And that's really how that drug particularly works. The important thing is that it binds to Beta2 receptors. So the Beta2 receptors are located within the sympathetic nervous system. It's an agonist, so it stimulates sort of the response. And so what happens is that as we know that when you stimulate the sympathetic nervous system, you end up with bronchodilation. And that's exactly what you're trying to achieve with this patient. You're trying to achieve dilatation of the structures in the lungs, the bronchioles, and that causes relaxation. This reduces bronchospasm, alleviates wheeze, and improves the work of breathing. And it also has an action on mast cells, which reduces histamine production, so hopefully would reduce the response that he's had. However, we also know that when we stimulate the sympathetic nervous system, what we end up with is sometimes an increase in heart rate as well. And that's exactly what happens with these patients. With the side effect of this drug is that a patient may well have a change in pulse rate, increase in pulse rate, feel quite tremulous, quite jittery, particularly if you're in the emergency department and you're giving back-to-back nebulizers, and they may well feel quite anxious. And that's because Beta2 receptors are not only located in the lungs, but they're located in the heart, in the gut, everywhere. And so what you'll get is a stimulation of that sympathetic nervous system when you give salbutamol. Okay, so that drug has caused bronchodilation by stimulating the sympathetic nervous system. So what does the ipratropium do? Well, the ipratropium is a muscarinic antagonist. So an antagonist is something that blocks and blocks the response, so reduces the action of the parasympathetic nervous system. Again, ipratropium is taken by inhalation. It has a direct action on the lungs, but a large proportion of the drug, again, is swallowed. And it may well be excreted by the urine and the feces, and it's got a slightly longer half-life of about 3.2 hours. That's really good because once the salbutamol sort of reduces, stops working, the ipratropium sometimes will stay in the system for a little bit longer and exert its effect for a little bit longer. So how do these drugs work? Well, ipratropium works on the parasympathetic nervous system, and going back to our slide, which looks at the action of the parasympathetic nervous system, when the parasympathetic nervous system is stimulated, what happens there is that there's bronchoconstriction. So what we're trying to do when we're giving ipratropium is trying to reduce that effect by preventing the interaction of acetylcholine within the muscarinic receptor and that acts on bronchial smooth muscle. And that results in that bronchoconstriction effect being prevented, and that ends up with relaxation of the structures inside the lungs, the bronchioles, and that causes relaxation. So it does exactly the same. Well, it does exactly the same thing as the salbutamol, but in a different way. This works on the parasympathetic nervous system instead of the sympathetic nervous system. What you get is your side effects that you'll get with this particular drug, because it's working on the parasympathetic nervous system to block the response to the parasympathetic nervous system. You'll end up with a dry mouth. You'll end up with perhaps a little bit of throat irritation and a cough, and you may well again feel a little bit anxious. So in summary, pharmacokinetics is what the body does to the drug. It involves a process of absorption, distribution, metabolism, and excretion. pharmacokinetics, there's some alterations in normal physiology that can affect how a drug passes through the body. For example, malnutrition may affect the distribution of a drug because of the reduction in the amount of albumin that's available in the body to distribute the drug around the system, resulting in more free drug and a potential for more toxic side effects. Liver failure may also affect how well a drug is metabolized. So you may well end up with an increased amount of drug available for distribution because some of it has not been metabolized by the liver. And sepsis will also affect how the body processes the drugs. Pharmacodynamics is what the drug does to the body. And there's many different drug actions that and they act on target receptors or enzymes or membrane transport systems or ion channels. We today looked at how drugs target receptors in the context of somebody with acute bronchospasm. And salbutamol and hypertropium are given together during acute reversible bronchospasm to exert that additive effect, thereby reducing bronchospasm. And many side effects can be predictable and explained by the pharmacodynamics of the drug. So we know that one of the side effects of giving back-to-back nebulizers with salbutamol is that a patient will have potentially develop a tachycardia, a tremor, and feel slightly anxious. And we also know by giving hypertropium, we know that as well as the reduction in bronchospasm that you will get, you will also get a dry mouth with those patients. So it's good to know that because you can explain to the patient and you can understand, if you understand how a drug works, you can also sometimes explain what the side effects of that particular drug is. I've given you some references here, which hopefully will help build on your knowledge. The Electronic Medicines Compendium is a great outline of how drugs work. It talks about pharmacokinetics and pharmacodynamics, and also some of the online information about how particular drugs work. Using stat pearls is really good to use. And there's just some information about a small study that was done that was looking at salbutamol and hypertropium together in chronic obstructive airways disease. So thank you very much. And I think we're going to open up the floor to some questions.
Hi, Ruth. Yes, thank you so much. That was a really fascinating whistle-stop tour of pharmacology, and there's been a lot of questions come through, so a lot of interaction with the people on the line. I'm just going to go through some of them. Some of them are quite specific, so you'll have to bear with me as I probably pronounce things incorrectly. So the first question we got was, in pharmacodynamics, do all drugs inhibit the endogenous activators? How is it happening, and what are the following steps of this process?
Okay, well, I'm probably just going to have to assume what some of the language is slightly different to the language that I might use. So not all drugs inhibit activators, that's for a start. Some drugs will stimulate activators, and those endogenous activators, which I guess are the neurotransmitters, I think is what you're talking about. Not all drugs do that. Some drugs will work on enzymes. Some drugs will work on membrane transport systems, and some drugs will work on other transport systems. For example, omeprazole will work on membrane transport systems as well. So they don't all work on neurotransmitters, no, but a large majority of drugs do. Some will inhibit and some will stimulate a response. When you're looking at enzyme inhibitors, they will actually inhibit the enzyme which produces something. So for example, if you're looking at something like an ACE inhibitor, an angiotensin-converting enzyme inhibitor, those drugs will inhibit the angiotensin enzyme, which will in turn reduce blood pressure, because that's involved in control of blood pressure.
Thank you, Ruth. We've got more. How are drugs related to plasma?
So when we talk about drug distribution, I wonder if I could go back to my slide. Is that okay? Can I go back?
Yes, of course. Yeah.
Hold on. Right. So So drugs bind to plasma proteins and they're transported in the plasma, bound to those plasma proteins. And that, I think that's, I'm not sure that that's what you're saying there, but those drugs will bind to those plasma proteins, and it's only the free drug that actually is available to exert the effect on that particular body cell. So so without those plasma proteins, the drug won't bind to that particular drug and not be transported, and then there'll be much more of the free drug available to exert its effect, and much more risk of people having toxic side effects as a result.
Thank you. Another question here: what is the difference between receptor and effector, and what types of interactions have we between these two in relation to drug effect?
What is the difference between receptor and effector?
Mm-hmm.
Effector is not a word that I'm familiar with when it comes to pharmacology, but the difference between, maybe it was my accent that didn't quite explain it particularly well, but in our autonomic nervous system, we have a variety of receptors, and drugs can either stimulate a response or block a response, and drugs that stimulate a response are an agonist, and those that block a response are an antagonist. So the drug effect will be determined as to whether or not that particular drug is an agonist or an antagonist.
Okay, thank you. We've got a couple of people just saying thank you very much for the presentation. There's one from Ahmed and an anonymous attendee. There's another question. I will read it out. I'm not quite sure of how it's phrased. Why are most drugs binding to HSA, such as warfarin, diazepam, etc.?
Suleiman, can you explain to me? We'll go on to the next question. I'm just not sure what HSA is. I'm sorry. Or you can email Deborah and I can get back to you by email, but I'm not quite sure what you mean there. Perhaps you could put it in the chat what you mean, and we could maybe go on to the next question.
Yeah, so the next question, I think this is how much aspirin absorbs in, I think that should be pregnant women.
Yeah, okay. So I can't say that off the top of my head, but the Electronic Medicines Compendium will tell us how much of a particular drug can be absorbed in particular situations. So they'll cover. So that's a really good resource that you can actually use to access information about particular drugs. And in pregnant women, aspirin is one of the drugs that we would advise, I think, that we would avoid in that particular situation. But because it's potentially known to be harmful. But what you can do is we use the British National Formulary in the UK, but you will have MIMS, or you will have some other drug formula that you can actually access. And that will tell you whether a drug is safe or not. And if you want any further information about how much of a drug is absorbed in pregnant women, you could go into the Electronic Medicines Compendium that would give you quite detailed information about that drug, its action, and how it works.
As we've got one here, why is salbutamol given with hypertropium if they have the opposite effects?
A very good question. So one drug is given, so let's just go back to these slides. So salbutamol is an agonist, okay? So it's a beta-2 receptor agonist. So that stimulates the sympathetic nervous system to exert a response, yep? So that results in bronchodilation, okay? Then you've got your hypertropium, which works on the parasympathetic nervous system. Remember, the function of the parasympathetic nervous system is rest and repair. So in your parasympathetic nervous system, if that's stimulated, what happens is that you'll get bronchoconstriction. So what you're doing is, when you're giving Hypertropium, is you're blocking that response. So you're blocking the effect of the parasympathetic nervous system, and because it's an antagonist, and that causes relaxation of the bronchial smooth muscles. So what you're giving is you're giving two drugs, that one works in the parasympathetic nervous system to block a response, and one that works on the sympathetic nervous system that stimulates the response. And what that ends up with is bronchodilation and a sort of additive effect of bronchodilation. So you get a much more profound bronchodilation with these patients, which is exactly what you want to improve gas exchange.
We've got a follow-up question from the same person saying, hello from Nigeria, thank you so much for the class. Can partial agonists and inverse agonists be classified as types of antagonist?
Yeah, that's a very good question as well. I think the drug classification and how that drug is classified is how it's licensed, and that's often determined about what the intended requirement of that particular drug is when it's developed. So it could be classified as that, but we would generally just try and stick to the classification of that particular drug that has been identified from the Drug Licensing Authority.
Thank you, Ruth. I do have a follow-up from Suleiman, who asked the question about HSA. He's responded saying, as human serum albumin. I don't know if that is helpful. We can follow up via email.
Yeah, I think what you're trying to say there, Suleiman, and please correct me if I'm wrong, is that you're saying warfarin is very, it'll bind to plasma proteins and be transported around the body. Now, sometimes if you give two drugs together, they will both compete for those albumin cells to be transported around the body, resulting in some of those drugs, there's an increased amount of free drug of one drug or the other, because they can't bind to the albumin because they've already been bound by another drug. I think that what you're trying to say is that sometimes, when you give those two drugs together, you'll end up with more free drug of one particular drug over another, which may well mean that you've got an increased amount of the free drug of one or the other. And that might mean that you have to reduce the dose, but I'm not sure whether that is what you mean. And if it isn't, please do get in touch.
Thank you, Ruth. I think we've covered now most of the questions. The final question was, a couple of people have asked if please they can have the slides. So I just wanted to say to everyone that the recording of this session will be available. It will be sent to you via email within a week. So please do look out for that, so everyone will receive the recording. And I just wanted to say a huge thank you to Ruth. Such a lot of information packed into that session, and really great interaction with the audience as well. Lots of really good questions coming through. And I just wanted to say a really big thank you on behalf of Elsevier for giving up your time to run this session for us.
No,
thank you so much. Thank
you. You're very welcome. And I'm really sorry if I didn't answer your question as comprehensively or incorrectly. Please just get in touch with Elsevier, and I'll do my best to try and answer the questions that you posed. Thank you very much.
Thank you so much.
Thank you.
Thank you, everyone.